Hello, everybody. Now we're going to move into Unit 4. We're going to start this unit with cardiovascular conditions, and then we're going to move into a topic that is related to cardiovascular conditions, but your book, for some reason, classifies it as gastrointestinal. So that's your chapter 34. And then we'll move into GI issues, which is the rest of the chapters for Unit 4. So let's jump in with chapter 26. And chapter 26 has to do with drug therapy for hypertension. This is a really important topic, especially here in our city, because we do have a lot of patients with cardiovascular conditions, specifically high blood pressure. So a little bit of overview is that antihypertensive drugs are the ones that we actually use to treat hypertension, in this case, a chronic disorder. Hypertension is important for us to address because it actually increases the risk for myocardial infarctions, which most of you guys know as heart attacks, heart failure, cerebral infractions, in this case, a stroke, and hemorrhage and renal diseases. And that's the reason you see sometimes patients with high blood pressure eventually develop renal failure because they do not control the blood pressure correctly. So the arterial blood pressure reflects the force exerted on your arterial walls by blood flow. That means pretty much think about your arterial vessel, because remember we have venous and we have arterial vessels. So the venous, of course, have lower pressure, and they carry deoxygenated blood versus the arterial vein, arterial circulation carries the oxygenated blood, and then also usually branches to the main, like, organs. Like you have your aorta, which will branch to like your kidneys and your liver and your heart and all those things. It usually remains constant because remember we're in constant movement, so that means that it will either go up or will go down with the movements that we're doing throughout the day. And of course, the main player in this is the homeostatic mechanisms, right? It will adjust either the blood vessel to either narrow down or dilate, so hopefully the blood flow can, go through with no problems. And you also know that in order for us to, be alive and have a good health, the blood tissues need to be supplied with the oxygen and nutrients necessary. There are two main determinants of the arterial blood pressure. One is the cardiac output, which is our systolic pressure, and the peripheral vascular resistance, which is our diastolic pressure. The really important thing for you to know is that cardiac output is equal to heart rate times stroke volume. Cardiac output is pretty much the amount of blood that is ejected by your heart per minute. Depending on the book that you are reading, because I know like some of you guys are taking anatomy and physiology or just took anatomy and physiology, you will see that the normal cardiac output is anywhere from 4 to 8 liters per minute. Sometimes you have books that go to 5 to 10, it all depends on the book, but pretty much think about that anything above 5, it's a good indicator that your heart is pumping adequately. The heart rate is really important component when it comes to cardiac output, because if your heart is too slow, your heart is not able to fill completely, therefore you don't have good cardiac output. And then the same thing, if your heart rate is too high, higher than 150, again you're not giving the heart enough chance to fill itself, and again the cardiac output actually will decrease. Stroke volume is pretty much the volume that your body actually has in the system. So like if somebody is dehydrated or constantly losing blood, of course, that's gonna diminish, and therefore what? It's gonna decrease your cardiac output. Same thing if there's too much fluid, because sometimes remember we have patients that have conditions that will make them retain fluid, making them having more volume. Then again, the heart only has certain capacity, and then is not gonna be able to completely pump the blood to other places, and again we have a decreased cardiac output. So Auto regulation of blood flow. Auto regulation pretty much is the ability of your body tissues to regulate their own blood flow. It is a really critical component when it comes to homeostasis because it allows us to preserve oxygenation and function of our major organs. Local blood flow is regulated primarily by nutritional needs of the tissue. Either produces vasodilation or vasoconstricting substances. So hopefully, the local circulation is maintained on that area. Histamine is found primarily in mast cells surrounding the blood vessels, and it is usually released when a tissue are injured. So when you get a cut or there's trauma, usually histamine gets released to hopefully, help with the vessel itself. And then bradykinin is released from a protein in the body fluids. The kinin dilate the arterioles, increasing the capillary permeability, and pretty much that what that means is that they'll either allow the vessel to be mold better or easier to whatever is happening around there. And what happens is it constricts the venules, and this actually will increase the blood flow to the local tissue. Serotonin is actually released from aggregation of platelets during blood clotting processes. Again, if there's blood loss, your body automatically reacts. It will release the serotonin and hopefully help with the clotting factor. And then prostaglandins are actually formed in response to tissue injury and include vasodilators and vasoconstrictors. So there are grades and types of hypertension. Normal or what we call optimal blood pressure, because we all are different. Some of us, like my normal blood pressure usually runs anywhere from 106, and sometimes I can go all the way up to 125. I think it just depends on, if I'm in stress or if I haven't eaten well or I've been eating a lot of salty foods and things like that. But the average, blood pressure that I usually run is like in the low hundreds, which you would not think about that be my blood pressure because I'm not like a really sporty person. But genetically speaking, that's usually what my family runs. My mom specifically runs as a blood pressure. When we diagnose someone with hypertension, is because we have seen a trend of persistent high blood pressure. And usually that means that it's been exceeding the normal levels. Usually, hypertension results because there's an abnormality in the regulatory mechanisms. Either, the hemostasis mechanisms are not functioning well, or maybe the patient has a condition that is increasing the blood pressure. Maybe we're giving them a medication that increases the blood pressure, so on and so forth. For the purpose of this class, and mostly every book that you may read, even the American Heart Association, you'll see that high blood pressure or hypertension is anybody that holds a systolic blood pressure above 80 and a diastolic pressure above, sorry, a systolic blood pressure above 130, sorry, milligrams per mercury, and a diastolic pressure above 80, and that is on multiple measures. So it doesn't mean that because you got 130 over 86 the first time means that you are gonna get the same, again. Uh, Box 26.2 actually classifies the types of hypertensions. There are pre-hypertension, type 1, type 2. Just keep a little bit quick of a read for that. So grades in hypertension again, a systolic pressure of 180, sorry, a 140 or greater with a diastolic pressure of less than 80 is actually called what we call an isolated systolic hypertension, and is really common in elderly patient. I got a call a couple of days ago of a friend. His dad was having headaches, and they were concerned because he was taking high blood pressure. Of course, he stopped taking them. He is a geriatric patient, of course, greater than 65, way greater than 65. So he was sending me the readings, and he was a little bit freaking out because he was getting like a systolic of like 120 over 55 or 60. And that is really common in elderly because as we age again, everything deteriorates, mechanisms kind of like decreases. And as a result, we have like this isolated systolic hypertension. Systolic and diastolic hypertension pretty much involves the elevation of both the systolic and the diastolic. Someone who is in what we call a hypertensive emergency or crisis is when they actually hold a blood pressure of 180 or more, and or a diastolic pressure of 120 millimeters of mercury or more. And we need to be really cautious because this can actually lead into organ damage. The highest blood pressure, I had a lot of patients with what we call, the hypertension crisis when I was in the cardiovascular intensive care unit. And the highest I've seen is 220 over 120, and the patient was having like this massive headache, and even we were giving him morphine and we were treating his high blood pressure. That massive headache was actually not going away as easy as we thought. So we need to make sure that when we have someone that has a hypertensive crisis, that we decrease the pressure within the 24 hours so we can prevent as much damage possible. So the etiology or hypertension. Well, there are different causes. Um, the essential hypertension causes is pretty much unknown, but we know that there's like genetic variations or there's inherited to, you having high blood pressure. Behavioral, like what you eat, you exercise, are you a couch potato? Environmental factors, maybe like you work in an like some of, you may work in a like high fast food, environment, and then that's the only food that you have access to it, so that can actually increase your blood pressure. These also include obesity, high alcohol intake, insulin resistant, salt intake in salt sensitive people, aging, sedentary lifestyles, high alcohol intake, and of course, the stress. We also have secondary hypertension, which usually results from either a renal, endocrine, or CNS disorder. And then sometimes we have drugs that can actually stimulate the SNS, and that causes the retention of sodium in water. Hypertension alters cardiovascular functions by increasing the workload of the heart and causing thickening and sclerosis of the arterial wall. The increased cardiac workload actually leads into what we call myocardial hypertrophy, which that means is pretty much your heart does not pump as it usually does. Because remember, you have those myocardial cells, so when you have hypertrophy, they are not as elastic as they should. So then we have the heart starts having like you know, um, more compensation of what's happening, and then it can actually lead, like I told you, to heart failure. As a result of the endothelial dysfunction and arterial changes, the arterial lumen narrows, body supply to the tissue decreases, and of course, we have a risk of thrombosis also. So, response to hypotension. So, like I said, you have hemostasis responses or hemostasis mechanisms when you either have hypo or when you have hypertension. So, when you have hypotension, what happens is your SNS is stimulated. And remember, you have your hormone epinephrine and norepinephrine, which will be secreted by the adrenal medulla. Angiotensin 2 and aldosterons are formed, and the kidneys will retain the fluid because remember, you don't have the pressure necessary. Other effects include the constriction of your arterioles and veins to hopefully retain as much pressure as possible, a stimulation of cardiac beta adrenergic receptors, and then activation of renin angiotensin aldosterone mechanisms, again, that they will help you retain as much fluid as possible. When you have hypertension, what happens is your kidneys start trying to excrete more fluids. So hopefully you can put more urine output, and then hopefully that will level down your blood pressure. Fluid loss reduces both external fluid and blood volume. And then decreased blood volume reduces venous flow and heart, and therefore decreases your cardiac output. And then, of course, if you decrease your cardiac output, you decrease your arterial blood pressure. And then the vascular endothelium produces a vasodilating substance, which hopefully will help you also reduce your blood pressure. So there are different things your body will try to do to hopefully, help you control your blood pressure. So, what are some of clinical manifestations of, oh, I went too fast. Sorry. Of manifestations of hypertension. Well, sadly, hypertension is probably one of the conditions that is less be diagnosed just because you start feeling bad. Is usually diagnosed like when you already have a heart attack or maybe a stroke or something, or because it rarely causes symptoms, because again, your hemostasis is like so smart that it will start compensating, and then your body will not actually have any signs and symptoms. If the symptoms occur, unfortunately, they're vague and unspecific. So you can go to the doctor and just say, I feel tired, and next thing you know, you may have high blood pressure. You see what I mean? It's like so vague. And then symptoms associated with hypertension include severe headaches, and that's usually when people have like really bad high blood pressure, nausea, vomiting, visual disturbances, neurological disturbances, disorientation, and decreased level of consciousness, and that includes like drowsiness, stupor, or coma. Hypertension is also, like I said, is often discovered after a person has experienced either chest pain, a heart attack, heart failure, a stroke, and renal failure. And and the bad thing is that once we discover it, sometimes it's too late. Like I have seen patients that never knew that they had high blood pressure, they have a stroke, and that was it. They didn't ever recover from the stroke. So therapy, we have different medications we actually use, which I'm really grateful that we do. But we also have pharmacological interventions that we can actually implement to either before we start therapy, medication therapy, or in combination with the medication therapy. So what is the goal of the treatment? Well, hopefully, to control the blood pressure, but it also depends on the population being treated. So if you have somebody who is 60 years or older without diabetes or chronic kidney disease, we want to maintain the pressure less than 150 over 90 millimeters of mercury. If you have somebody who is 30 to 59 with diabetes and chronic kidney disease, we want it to be less than 140 over 90 millimeters of mercury. And of course, if you have a young person like 18 to 30 years, the goal is to hopefully keep them less than 140 to 90. Non-pharmacological interventions, of course, will be exercising, uh, moderate alcohol intake, and no smoking. The one that is really hard for a lot of people that have high blood pressure is reduction of the weight and also the sodium intake. My mother-in-law has high blood pressure, and the other day, like, she made a comment about like going into McDonald's and it was not salty enough, so she decided to add more salt, and I was just like, no, don't do that, because we know that McDonald's food originally already has high sodium in the food. So anyway, and I think that's really hard because sometimes we don't know what has salt and what doesn't have salt. So I don't blame her. Dietary management, like I said, diet low in sodium and fat, along with an increased consumption of fruit, vegetables, and grains, which is usually known as a DASH diet. Also, like we want them to physically, uh, to have a regular physical activity to hopefully help them. When it comes to drugs, well, we will, like I said, we will try to do it with life modifications, but if it does not, that doesn't help, then we'll have to use medication in combination with the life modifications. We have 5 medications that we use with high blood pressure. Two of those we're actually gonna have talked specifically in other chapters. For example, your diuretics and your vasodilators will come up in another chapter. So the ones that we're going to talk about in this chapter are your angiotensin converting enzymes, or what we call ACE inhibitors. We have your angiotensin 2 receptor blockers, your ARBs, and you have your calcium channel blockers, CCBs drugs. Like I said, diuretic, since it has multiple uses, they actually decided to put it in a whole chapter. And then you have direct vasodilators that sometimes we use under emergency situations. So let's talk about ACE inhibitors. The medication we're going to talk about is captopril. The best way to remember ACE is just think about April. And there's actually a meme that I will probably be sharing later with you guys that says April. I'm not sure if it's an ACE inhibitor or a month. You know what I mean? It's an easy way to remember this drug. This is usually the first line of defense when it comes to treating hypertension. We can be used by itself or can be used with combination with other medications. It is a drug of choice for diabetic patients because when they do not have renal impairment, it actually protects their kidneys. It reduces the proteinuria, which is formation of the protein in their kidneys, which usually is the one that causes the kidney to get damaged. So that's the reason we like to use it with diabetic patients. Mechanism of action, as its name says it actually blocks the enzyme that normally converts from angiotensin 1 to the potent vasoconstrictor angiotensin 2. And because it doesn't allow to constrict, the vessel is dilated and then it will reduce your pressure. The adverse effects are really low, but it does have such as like neutropenia, granulocytes, proteinuria, glomerulonephritis, angioedema. One important thing is that if the patient develops a cough, even though it's a normal adverse effect, because it is a normal adverse effect of the ACE inhibitors, we have to let the provider know because they need to discontinue the medication. So when I had patients in the ICU and they were put in a ACE inhibitor and then a couple of days they will start developing the cough, they will always ask me why they cannot keep the medication. And unfortunately, the cough does not go away. It is a persistent cough. And it actually interferes with their activities of the daily living to the point that they cannot sleep. So that's the reason we want to discontinue because you don't want to have a tired patient, right? It can also cause hyperkalemia, especially in those patients that have diabetes and impaired renal function. So we want to make sure that we don't use it with them. Nursing implications, of course, we need to monitor that the medication is actually doing what it needs to, and of course, that the patient does not develop any adverse reactions. The next one is angiotensin 2 receptor blockers, or ARBs. The medication that we're going to be talking about is losartan or Prozac. The mechanism of action, again, it will block the vasoconstricting and the aldosterone secreting effect of the angiotensin 2. And this is actually at various receptor sites. And because of this, again, angiotensin 2 get not released, and then again, vasodilation occurs. Adverse reactions, again, dizziness, muscle cramps or weakness, heartburn, diarrhea, and decrease sensitivity to touch. The main thing with this one is that we're worried that the patient will develop an angioedema, which is a condition that we have to evaluate immediately because that means that we probably will have to discontinue the medication. Angioedema, as it says, is just a swelling from everywhere, like your extremities, your legs, your arms, and all that stuff. Implications, we want to make sure the patient takes this medication on an empty stomach, and of course we want to make sure that the blood pressure is controlled. I usually like ARBs a lot because when ACE inhibitor does not help us to do the magic, usually ARBs does. The other thing that you have to think about is that when you cannot use ACE inhibitors on those diabetic patients with renal failures or patients that have renal failures, this is actually the drug of choice after that. Okay. And then the third one we have is calcium channel blockers. amlodipine or Norvasc. This is actually the first line of defense to control hypertension, and I think it's on African American population. And you're gonna be like, why they have a different medication to treat African American population? Well, the reason they do is because unfortunately our black population or our African American population I are sorry I they are at high incident, my bad, of high blood pressure, and it's just generally predisposed. I actually had a patient once that was in nine, I think it was like 9 or 11 high blood pressure medications, and he had already had 3 strokes. And it wasn't that he wasn't taking care of himself. It wasn't that the medication was not working. It was just that the genetics that he was carrying, unfortunately, was not helping him, to control the blood pressure. Mechanism of actions of calcium channel blockers, pretty much it inhibits the influx of calcium, as the name says it. And then by doing this, it causes like relaxation and vasodilation of the vessel. And then, that actually helps us to decrease the blood pressure. Adverse effects you have is peripheral edema of hands, ankles, and feet. It can also cause pulmonary edema, particularly in those patients that have heart failure. It can also cause drowsiness, fatigue, flushing, palpitation, nauseous, and abdominal pain. And then, of course, we want to assess the therapeutic and the adverse effects. One thing that I forgot to mention to you guys, that regardless of what medication you're using, high blood pressure medication that you're using, unfortunately, because it can cause dizziness, especially on the first dose. So anytime that you give your patient their first dose to treat their high blood pressure, you want to make sure that you instruct them to move slowly when they change positions, because it can actually cause what we call orthostatic hypotension. And when it does that, the patient is at high risk of falling. So we don't want them to fall, because then they can hit themselves and then we cause another problem, right? Adjuvant therapies, like I said, we have other types of medications that we can use. You have different classifications, like the direct renin inhibitors. You have the antiadrenergic, drugs. You have the alpha 2 agonists. You have beta adrenergic blockers, which we're actually going to talk about in other chapters. You also have diuretics. Like I said, I also talk about them in another chapter. But pretty much think about that they will help you either decrease the volume or somehow cause a dilation of the vessel, which hopefully will decrease the pressure in there. Okay, so that's it for the chapter.